Good afternoon, everyone. Today I will be discussing a unusual presentation. A 14-year-old presented with bilateral disc edema with unilateral retinal detachment. This case, there was a Wicked syndrome versus IIH, a diagnostic dilemma. Now, as we all know, VKH is an idiopathic T-cell mediated autoimmune inflammatory disease involving multiple systems, most commonly nervous, ocular, auditory and integumentary system. It is prone to be misdiagnosed and treated as other common diseases like idiopathic intracranial hypertension, especially in its prodromal stage in view of headache and visual symptoms, which may be sometime lead to delay in early diagnosis and vision-threatening complications. A 14-year-old female presented to our ophthalmologist complaining of sudden diminution of vision in both eyes that had been occurring for the previous 5 days. It was associated with diffuse headache and nausea. There was no history of diplopia, hearing loss, tinnitus, alopecia, vitiligo or any previous ocular surgery or any trauma. On ocular examination, right eye visual acuity was hand movement close to face with accurate perception of light in all quadrants. Anterior segment, there was no cells, no flare or no chorotic precipitates. Pupillary reaction was RAPD grade 2. Extraocular movements were restricted temporarily. On fundus examination, there was masked disc edema with elevated disc margin with exudative retinal detachment which was surrounding the disc with tortuous blood vessels and few hemorrhages in all quadrants. On left eye examination, visual acuity was found to be finger counting close to face with accurate PL in all direction. Similarly, there was no cells and anterior segment was quiet. Pupillary reaction was sluggish. Extraocular movement was within normal limits, and on fundus examination, there was marked disc edema with elevated disc margin, mild tortuous blood vessels, and normal maculofoveal reflex. On further investigation, complete blood count and other systemic evaluation was done to rule out any infectious as well as autoimmune etiology. OCT was done and right eye OCT was there was found to be subretinal fluid, whereas on left side OCT there was mild edema present. B scan was suggestive of thickened retinocoroidal complex. MRI was suggestive of raised intracranial pressure. There was an optic nerve sheath distension and flattening of the globe in absence of any mass lesion, which was primarily suggestive of idiopathic intracranial hypertension. On lumbar puncture, there was mildly elevated opening pressure with mild pleocytosis. MR venography was done to rule out sinus vein thrombosis, and there was no abnormality noted. This is the picture of the OCT. There were due to the lack of signs of anterior uveitis and other clinical findings, this coming to the diagnosis was troublesome. But as there was a presence of unilateral exudative retinal detachment, which is an atypical feature for IIH, hence a diagnosis of incomplete Wicked syndrome was made in the presence of IIH-like imagining. Patient was further subjected to IV MPS 1 gram per day for 5 consecutive days, following which the visual acuity improved to 4 mm finger count in right eye and 6 MFC in left eye. Unfortunately, the patient was further lost to follow-on. So to conclude, Wicked syndrome is an autoimmune disease with myriads of signs and symptoms which can be misdiagnosed with other clinical entities, like in our case as idiopathic intracranial hypertension. A thorough history with both systemic and ocular examination with relevant investigations will lead us to a conclusive diagnosis, thereby helping clinician to start with prompt treatment and prevent vision-threatening complications.